Seniors, the members on the moderator's desk, in the gathering, juniors. Special thank you to a team of cardiology from Elite, Kiran Chetan and Dr. Manigandan for giving me this opportunity. I'll be talking about a spurious, occasionally maybe encountered case of high cholesterol LDL levels. This was a 39-year-old female admitted in the gastrointestinal GE department for the evaluation of obstructive jaundice. She was a diabetic, hypothyroid and hypertensive on treatment, and she had recently taken alternative medications, and it was suggestively for the cause of the jaundice. She was referred to cardiology and endocrine for this highly abnormal lipid profile. Her bilirubin was elevated, SGPT, OTPT and ALP was also elevated, suggesting cholestasis. Her total cholesterol was 758 with an LDL of 676. She had a low HDL level. Triglycerides were also elevated. Other parameters were normal, CRP, creatinine, blood sugar was controlled. Actually, the cause of this level of LDL was truly not an LDL. In patients with liver disease, what happens is there is an abnormal formation of a lipoprotein called lipoprotein X. It is truly not a lipoprotein like our LDL or VLDL. It has a lipoprotein density like that of an LDL, so it is detected by our blood reports as LDL, but it is not a true lipoprotein. It has the density of LDL, but the size of the vesicle is larger, 30 to 70, like that of a VLDL. It is predominantly phospholipids, unesterified cholesterol and albumin. But it does not have a micellar structure or in any significant or any apolipoprotein, that is the apolipoprotein B100, which is a marker for our lipoproteins. This high level of lipoproteins causes hyperviscosity, and this is the main cause of symptoms in these patients. The long-standing cases in patients who have cholestasis due to congenital causes like primary biliary cirrhosis, they may develop xanthomas due to this high level of lipoprotein X. The main content is the bile acids, and the predominant bile acid is the lithocholic acids. There have been 3 species of lipoprotein X that have been described. The main pathophysiology is cholestasis. Due to cholestasis, there is decreased degradation and increased formation of bile acids, and there is also reduced formation of cholesterol esters. It is only the cholesterol esters that can be transported through the lipoproteins to the tissues. So increased free cholesterol and increased bile acids, they combine with albumin to form the lipoprotein X. So there is an albumin core surrounding which there is free cholesterol and bile lipoprotein. The cause for cholestasis can be intra or extrahepatic, and there are mainly 4 etiologies that have been described. That is liver dysfunction due to any cause, LCAT deficiency, that is lysine cholesterol acetyltransferase deficiency. In this deficiency, there is reduced conversion of free cholesterol to cholesterol esters. Then increased lipid infusions like that for a parenteral therapy, or it has also been described in a post-transplant patient with graft versus host disease. As apolipoprotein B is absent in lipoprotein X, it cannot be taken up by the LDL receptors. So it is not degraded by the usual LDL receptor mediated. It is mainly found to be degraded by the reticuloendothelial system and also a small role by the kidney. This highly elevated lipoprotein X does not have any feedback inhibition for the production of cholesterol, because it is not detected by the LDL receptor. So what happens is the body is not able to get the lipoprotein, so it will enhance the production by increasing HMC coenzyme reductase, and also there is also reduced uptake of cholesterol remnants by the lipoprotein X. So this leads to further increase in the cholesterol levels, predominantly triglycerides. One study suggested that the lipoprotein X formation might be a defense mechanism to prevent the free cholesterol deposition in the tissues. Also, this is evidenced by the fact that patients with increased lipoprotein X, especially the patients of primary biliary cirrhosis, they do not have an increased cardiovascular events compared to normal age matched populations. As I mentioned, these patients with PBC with high lipoprotein X have increased cutaneous xanthomas. So the diagnosis is the difficult part. We have to suspect LPX in patients with grossly elevated lipid profile in the background of cholestasis. Although lipoprotein X levels can be measured by agarose gel electrophoresis ultracentrifugation, the method of choice is nuclear magnetic resonance spectroscopy, but it is not available. So what we can do is we can measure ApoB100 levels. As LPX does not have ApoB100, a low LPX level means the elevated LDL fraction is not true LDL, it is apolipoprotein X. Management, treat the primary cause. In case of cholestasis due to any obstruction, treat the obstruction, avoid lipid infusions, management of the GVD disease. The symptoms are predominantly due to hyperviscosity. So the treatment of hyperviscosity is important. LDL charging therapy like our statins, our estimab or our evolocumab does not have any effect, as this is not cleared by usual LDL receptor or the apolipoprotein B100 marking agents. Only effect from an oral medication that is found to be by cholesterol sequencing, colsevelam, colestipol and cholestyramine. This has found to reduce LPX levels marginally. Only definitive treatment that is possible for LPX is plasmapheresis, and it is only reserved for patients who have hyperviscosity related symptoms. Take home message: grossly elevated LDL patients in cholestatic patients always think of LPX. Routine treatments do not work, may try with cholestyramine, manage underlying cause, and plasmapheresis as the last measure. I would also like to add another lipoprotein Z. Unlike lipoprotein X, lipoprotein Z is a pathogenic lipoprotein. It has apolipoprotein B. It is usually seen in alcoholic hepatitis and is better managed and treated, unlike lipoprotein X.
Thank you, Dr. Sultan. It was an excellent case. So I think if we are getting very high LDL or total cholesterol levels, go for ApoB level. See whether it is elevated or not. If it is not elevated, it can be possibility of lipoprotein little x. It is not a big concern for cardiovascular physicians, but it is a concern for liver physicians. Thank you.
Get these outrageous levels of LDL. When first think of familial hypercholesteremia, because these are rare causes of this thing. But then, as Rupesh was mentioning, normal ApoB means, well, you are safer, and this is, you have a telltale evidence of a cholestatic disease here. So thank you very much.